Good morning, everyone. My name is Ruth Mächler. I'm working at the Technical University of Munich, and I have the honor of presenting to you today the first results of a study we are currently conducting at the Professorship of Spiritual Care, the pause. The pause can be described as following. It is 1 minute of silence immediately after death at the patient's bedside to honor the deceased and the efforts of the staff. Participation is always voluntary. Invited are those involved in the care and treatment of the deceased and the deceased relatives, if they wish so. The pause is not meant to be a religious ritual, nor is it a team meeting. At the beginning of the pause, one person reads a short text. The words are decided jointly by the team during the process of implementation, and they are then always the same. They go something like this. In this pause in time, in our own way, and in this moment of silence, we honor Mrs. X, and we also pay our respects to those who have loved her and cared for her. And after the minute of silence, thank you, everyone. The data I will present today is the first step in a two-phase study. In phase 1, ICU teams have been invited to participate in the study. After the presentation, we have conducted a survey, asking them, what do you think about the proposal? In phase 2, the pause will be tested in a randomized controlled trial for 2 months, and we will collect data to assess its effects via in-app questionnaires. Currently, we are in phase 1, and our research question is, how does ICU nursing staff react to the proposal of a minute of silence after the death of a patient? So far, I have analyzed 30 interviews with nursing staff. You can see the demographics in the table on the slide. Positive and negative expectations were mentioned. These included the expectation that the pause would help me to process the event, that it would bring dignity, and that it would improve the team spirit. On the other hand, the nurses expressed concern with lack of time, lack of openness on the part of team members or the hierarchy, and disruption of one's own strategies to deal with death. In my presentation today, I would like to talk about a third variant, ambivalent statements. Statements that reveal an inner conflict that comes to the fore when nurses consider the invitation to pause after the death of a patient. I want to give you first a longer example and then highlight different aspects. Here we have a nurse, and I read to you what she said. And then I step from one foot to the other because I know exactly that I have to get on. I think it's this workload you have to manage. So I don't know if I would stand next to the dead patient now, and then tears well up in her eyes. The interviewer says that would be a completely different approach. The intensive care unit concentrates very much on the physical, and that would be something metaphysical. And then the nurse says, yes, and you can't afford that here. So as I said, some may suffer, and we build a wall around ourselves and know that the work is the main focus here. And you might get pretty tough. And then in situations like that. But that's now an impulse, this minute silence, to reflect on myself and ask, how am I in a situation like this? Can I dial myself down? Can I approach this a little more reverently? Of course, but whether I would do it is another question. So we see she expresses here both sides. She goes back and forth. She has to function. She's under pressure. Work needs to be done on one hand. On the other hand, there are her tears. And there is the thought to approach those situations more reverently. It is a conflict that she has within herself. I have here some more examples that show aspects of this inner conflict. So one person says, devices, medication. In the end, you forget that there's a living being there. A person who would be my father, my mother, my brother. I don't know. But I think that's a kind of protection that we've all built up over time, so that you can do what you do. And another person says, I want to be as close to the dying person as possible, but at the same time as far away as possible. And then there's a person who says, so there are certainly colleagues who somehow bottle it up, eat it up in the end, because they simply have to work for the other patients. And taking a quick breath when a patient dies is not actually supported, especially in intensive care. You already calculate the bed where the patient is dying, where you're actually waiting for them to die. And as soon as he is taking his last breath, so to speak, the bed is occupied again. And in the last example here, the interviewer says, are we perhaps afraid of the silence, of the peace that death creates? The nurse starts to cry and says, yes, sorry. The interviewer, it's all right. The nurse again, I had the feeling that they weren't gone, that the body had died, but they were still there. The inside is still there, the soul, and that it knows that you still treat it well. So we see here that the nurses are in something like a double bind. They are in a dilemma. As nurses, they are expected to bring humanity, respect and dignity into the system, and they indeed feel the personal responsibility for this, while at the same time the structures function according to a different value system that demands efficiency, standardization, and professionalism. So they find themselves in a double bind. The messages are, take care of dignity, but don't spend time on it. Be human, but function like a machine. These contradictory requirements create a field of tension in which carers have to operate on a daily basis. They try to solve the problem individually, but it can only be solved on an organizational level. We all want to be treated with dignity as patients, and the people who do this work want that too. But this claim cannot be realized on an individual level. We need to look at the system. If the structures we create do not give room for respect and dignity, we cannot demand of the people who work in these structures to sneak them in against the protocol. But we have to be careful now that we do not just scapegoat hospital managements or politicians. A society that is not willing to pay for dignity in its healthcare systems and that numbs itself to the fact that everyone will one day die also needs to reflect its priorities. So based on these findings, I want to return to a topic that stands generally in the focus of our work here. It's the consideration of spirituality in healthcare. A healthcare system that does not take into account the spiritual aspects and needs of human beings forces those who are cared for within it and those who work in it into tensions and contradictions that cannot be resolved at the individual level. We need to design the structures of the healthcare system in a way that takes this into account. I thank you for your attention.